Welcome to this revision deep dive. Today we are taking your pristine two-dimensional anatomy atlas and, well, dropping it right into the three-dimensional high-stakes minefield of the operating theater.
Yeah, where things get a lot more complicated.
Exactly. Our mission today is a rapid-fire, high-yield question and explanation review of head, neck, and spine anatomy. We are tailoring this specifically for you, the surgical resident preparing for the MRCS exam. So no wasted time today.
Right, straight to the facts.
We are getting straight into the surgical facts and the anatomical mechanisms you absolutely need to know. But first, head to medsynclimited.com/Anki and grab the MRCS Accelerator ANKI deck.
Highly recommend that one.
Yeah, it contains over 2,400 questions across 23 themes. That includes 15 subspecialty topics, and it's designed specifically to help you recall commonly tested facts.
Which is exactly what you need for this exam.
Totally. You should also head to medsynclimited.com to get their surgical simulation kit. That includes a suturing kit, microsurgery instruments, and a bunch more. Hit follow on the show to listen to more deep dives and rate it if you learned something today. All right, let's initiate this clinical anatomy review at the very beginning, embryological origins.
It really is the only logical starting point. Because developmental anomalies present in surgical clinics so frequently.
Right.
If you don't understand how they formed in the first place, you're going to be lost.
Right.
We have to look at how the face and neck structures actually form in utero.
So the fetal pharynx is essentially supported by these branchial arches, right? Which are basically just blocks of mesoderm.
Exactly. And if you fail to understand the migration of those arches, you will fundamentally fail to understand the congenital neck masses, the fistulas, and the clefts that you are definitely going to encounter.
And the trick with the branchial arches, the high-yield trick, is that wherever that mesoderm migrates, it drags its nerve and its artery right along with it. So let's break down the highest yield derivatives. The first arch, or the mandibular arch, is supplied by the trigeminal nerve, cranial nerve 5.
Right.
So logically, it forms the muscles of mastication, and skeletally, it forms the incus and the malleus in the ear.
And the mechanism there is what's crucial. Because that trigeminal nerve is embedded in that first arch mesoderm, any muscle that eventually develops from that specific block of tissue, like, say, the masseter or the temporalis, it has to be innervated by the trigeminal nerve.
No matter where it ends up.
Exactly, no matter where it eventually shifts in the adult face. And the second arch, the hyoid arch, follows that exact same rule.
Okay, so what supplies the second arch?
It's supplied by the facial nerve, cranial nerve 7. Therefore, the mesoderm from this arch forms the muscles of facial expression. And skeletally, it gives us the stapes in the ear and parts of the hyoid bone.
I love that. You just trace the nerve function back to the arch, and the anatomy basically maps itself.
Yeah, it takes the memorization out of it.
Let's look at another major embryological migration, which is the thyroid gland. It begins its development as a diverticulum from the floor of the embryonic pharynx, specifically at the foramen caecum of the tongue.
Right up there.
Yeah. And I've always pictured the descending embryonic thyroid gland as this like rock climber, rappelling down the neck to its final position overlying the trachea.
That's a great visual.
And as it rappels, it leaves a safety rope behind it. That rope is the thyroglossal duct.
Right. And in a typical developmental pathway, that duct eventually obliterates. It disappears entirely.
But no less.
No. In a clinical setting, we frequently see patients where traces of that duct remain. The epithelial remnants secrete fluid, and that forms thyroglossal cysts anywhere along that midline descent path.
Which brings up a very specific surgical scenario for the MRCS. When we operate on a thyroglossal cyst, doing a cyst trunk procedure, we don't just pluck out the cyst. We have to excise the central portion of the hyoid bone along with it.
You absolutely have to.
Walk us through the physical mechanism there. Like, why is leaving the hyoid intact a surgical failure?
Well, it comes down to the exact three-dimensional path that your rock climber took.
Okay.
As the thyroid diverticulum grows caudally, it doesn't just slide cleanly past the branchial arches. The thyroglossal duct intimately attaches to, and it sometimes even passes straight through, the developing body of the hyoid bone.
Oh, wow. Straight through it.
Yeah. So you physically cannot clear those microscopic epithelial tracts without taking the central body of the hyoid. If you leave that bone segment in there, the anatomical anchor remains, and the recurrence rate of that cyst just skyrockets.
Right, so you really have to follow the embryological tract down to its core.
Exactly.
Staying with facial development, let's look at fusion failures, specifically cleft lip and cleft palate. We often see these grouped together clinically, but structurally, What are the specific migrating elements that fail to fuse in each condition?
They're completely distinct failures of migration. So the face forms from processes growing inward to meet in the midline, right?
Yeah.
For a cleft lip, the physical failure of fusion occurs between the maxillary processes, which are growing in from the sides, and the front nasal process dropping down from above.
Okay.
If they don't meet, you get a cleft on one or both sides of the philtrum.
So the lip is specifically a failure of the maxillary and frontonasal processes.
Correct. But for a cleft palate, we are looking much deeper inside the oral cavity. The failure here is between the primary palate, which is that small anterior wedge of the premaxilla that holds the four incisor teeth,
Right.
and the secondary palate, which forms the broad, horizontal shelves of the hard and soft palate. If those shelves fail to swing upward and fuse in the midline, the oral and nasal cavities just remain connected.
Makes sense. And those embryological structures eventually ossify to form the anterior boundaries of our next topic, which is the adult skull base.
A very popular exam topic.
Oh, massively. We are moving from development strictly into adult anatomy now. The skull base is an incredibly dense, high-stakes area for any trauma surgeon. Knowing exactly which nerves pass through which foramina is a favorite testing point on the MRCS?
Oh, yeah. It is essentially a multi-tiered stadium holding the brain, but the floor of that stadium is perforated by these tiny bone canals transmitting all these vital nerves and blood vessels out of the cranium.
So any fracture running through those tiers acts like a guillotine.
Exactly. A literal guillotine.
Let's start on the top tier, anteriorly. The anterior cranial fossa is formed by the orbital plate of the frontal bones and the cribriform plate of the ethmoid bone. Now, cribriform plate is terrifyingly thin.
Paper thin.
Right. If a trauma patient fractures this specific area, the clinical signs are deeply tied to what sits directly above and below it.
Yeah, because the orbital plate forms the roof of the eye socket. A fracture there bleeds directly down into the orbit, which you will see clinically as a massive subconjunctival hemorrhage. Furthermore, that thin cribriform plate roofs the nasal cavities and transmits the delicate olfactory nerve filaments. A shear fracture there just severs those filaments entirely, causing anosmia or, loss of smell.
But the more dangerous consequence of a cribriform fracture is dural tearing, right? Because the dura mater is so tightly adherent to the bone there, a fracture easily tears the meninges, which allows cerebrospinal fluid to leak straight into the nasal cavity, CSF rhinorrhea.
Yeah, and that is a massive problem. That fluid leak creates a direct open highway for bacteria from the unsterile nasal cavity to travel right up into the brain, causing meningitis.
Not what you want. Okay, moving back one tier, we hit the middle cranial fossa. I often visualize the middle fossa as a heavily perforated piece of Swiss cheese.
That's a good way to look at it.
It's formed by the sphenoid and temporal bones, and it is absolutely littered with foramina.
And structurally, all those holes make the middle fossa the weakest point at the skull base. I mean, it absorbs stress terribly and is highly prone to transverse fractures.
Let's map out that Swiss cheese. The superior orbital fissure is the major gateway into the eye socket. It transmits cranial nerves 3, 4, and 6, oculomotor, trochlear, and educens, plus the ophthalmic division of the trigeminal nerve and the ophthalmic veins.
Right.
If we move slightly inferior and posterior to that, we find the foramen oval.
And the foramen oval transmits the mandibular division of the trigeminal nerve, dropping straight down into the jaw.
Okay, and right next to that is the foramen spinosum, which is small but deadly. It transmits the middle meningeal artery. Let's look at the mechanism there. If the skull is fractured laterally at the poterion, the bone fragments easily lacerate that middle meningeal artery.
Very easily.
But why does that specifically create an epidural hematoma, rather than just bleeding into the brain tissue itself?
Well, it has to do with the layers of the meninges. The middle meningeal artery runs between the skull bone and the periosteal layer of the dura mater, so it is essentially embedded in the wall.
Okay.
When it ruptures, the high-pressure arterial blood aggressively peels that tightly adherent dura away from the inner table of the skull. That creates a localized lens-shaped pocket of blood, an epidural hematoma. It compresses the brain inward rather than bleeding into the subarachnoid space.
Got it. Let's test this anatomy with a specific trauma bay presentation. Say a patient comes in with a severe head injury. Imaging shows a fracture involving the tegmen tympani in the middle cranial fossa. What is the physical mechanism of that fracture, and what exact clinical presentation must we look for?
So the tegmen tympani is a paper-thin sheet of petrous temporal bone, Crucially, it forms the roof of the middle ear cavity, separating the ear from the temporal lobe of the brain.
Oh.
If a fracture line runs through the tegmen tympani, the middle fossa bleeds directly downward into the middle ear.
So we look in the ear canal with an otoscope.
Exactly. If the pressure from that blood ruptures the tympanic membrane, you will see frank bleeding just pouring out of the external ear. You also have to check for CSF otorrhea, cerebrospinal fluid leaking from the ear. Additionally, because the fracture propagates through the petrous temporal bone, it often crosses the internal acoustic meatus. This puts cranial nerves 7 and 8, the facial and vestibulocochlear nerves, right in the crosshairs. You must immediately assess for unilateral facial paralysis or sensorineural hearing loss.
That makes total sense. To finish the skull base map, we drop down into the posterior cranial fossa. The major exit point here is the jugular foramen. It transmits the internal jugular vein and a trio of cranial nerves, 9, 10, and 11, the glossopharyngeal, vagus, and accessory nerves.
And a basilar skull fracture here can damage any of those nerves, which impairs swallowing or shoulder elevation, and typically causes bruising at the back of the neck or even bleeding down into the pharynx.
Right. Now, those cranial nerves and vessels don't just hang in empty space once they exit the skull base foramina, they plunge into the neck, which brings us to our next major architectural concept. The neck is compartmentalized by tight fascial layers and anatomical triangles.
Very tight.
And it dictates exactly how we operate and how pathology spreads.
Yeah, fascia in the neck isn't just connective tissue. I mean, it acts as a series of physical barriers and potential spaces. You have the investing layer, which wraps the entire neck like a tight cylinder, and it splits to enclose muscles like the sternocleidomastoid. Deeper than that, the prevertebral fascia covers the cervical spine and the deep back muscles.
And anteriorly, we have the pretracheal fascia, which encloses the thyroid gland and the trachea.
Yeah.
But the fascial structure that gets tested relentlessly on the MRCS is the carotid sheath.
Oh, absolutely.
It runs vertically through the neck. Structurally, it contains the common and internal carotid arteries medially, the internal jugular vein laterally, and the vagus nerve positioned posteriorly between the two vessels.
And the structural design of the carotid sheath is brilliant. The fascial wall is thick and unyielding over the high-pressure carotid arteries to provide protection. However, the fascia is remarkably thin and weak over the internal jugular vein.
Wait, why the asymmetry? Why leave the vein vulnerable?
It's to allow for rapid venous expansion. Whenever intrathoracic pressure spikes, like when you cough, strain, or sing, venous return to the heart briefly stalls, and the internal jugular vein just balloons outward.
Oh, I see.
Yeah, the thin fascia accommodates that massive volume change without compressing the vagus nerve.
That's a great detail. These fascial layers form the boundaries of the anatomical triangles. Let's look at the posterior triangle. It is bounded anteriorly by the sternocleidomastoid, posteriorly by the trapezius, and inferiorly by the middle third of the clavicle. Surgeons are terrified of doing lymph node biopsies in this triangle. Walk us through the anatomy of why.
The danger lies directly with the spinal accessory nerve. After it exits the jugular foramen, it emerges from behind the sternocleidomastoid and crosses the posterior triangle obliquely to supply the trapezius. The issue is its depth.
It's too shallow.
Way too shallow. It is embedded superficially right in the fascial roof of the triangle. It isn't buried under deep muscle at all.
So an incision for a superficial node biopsy can easily sever it. And if you cut that nerve, the trapezius loses motor supply, the patient's shoulder droops, and they can no longer shrug.
Exactly.
Moving anteriorly, these fascial compartments also house the salivary glands. Let's trace the facial nerve into the parotid gland.
Right, so the facial nerve exits the skull at the stylomastoid foramen and dives directly into the substance of the parotid gland. The critical concept here for exams is that the facial nerve does not innervate the parotid gland.
Okay, that's cute.
It merely uses the gland as a transit hub, dividing within the tissue into its 5 terminal motor branches.
And the easiest way to visualize this during revision is the hand analogy. Splay your hand across your face with the heel of your ear. Your thumb pointing up is the temporal branch, your index finger is the zygomatic, your middle finger is the buccal, your ring finger is the mandibular branch, and your pinky dropping down is the cervical branch.
And the mandibular branch, that ring finger, requires massive surgical respect.
Let's explore the surgical margins there. The mandibular branch is the longest, thinnest, and most vulnerable of those terminal branches. During an external approach to the submandibular gland, a surgeon has to navigate around it. Where exactly must the skin incision be made to avoid paralyzing the lower lip?
While the anatomy dictates the margin perfectly, The mandibular branch doesn't just run straight across the jaw. It actually descends in a loop below the angle of the mandible before arching back upward onto the face to supply the depressor muscles of the lower lip.
Oh, so it dips down.
Yes. Because of that downward loop, the safe zone for a submandibular incision is strictly more than 2.5 centimeters below the angle of the mandible.
Less than 2.5 centimeters, and you risk catching the bottom of that nerve loop, resulting in an asymmetrical smile and drooling.
A very bad day in the OR.
Exactly. The submandibular gland has another bizarre anatomical relationship, this time inside the floor of the mouth, involving the lingual nerve.
Right. The lingual nerve, which supplies sensation to the anterior tongue, physically wraps around the submandibular duct, Borton's duct, as the duct runs forward to empty under the tongue.
I often hear it described as a double cross. Walk through the physical routing for us. How does the nerve cross the duct twice?
So it starts laterally. As the lingual nerve descends from the jaw, it lies lateral to the duct. It then passes inferiorly, looping underneath the duct, and finally ascends to sit medial to the duct as it enters the tongue tissue.
So it literally hooks under it, going lateral to medial.
That's it.
And that spatial routing is crucial when trying to remove a stone from the distal duct. Let's shift slightly medially into the anterior triangle, dropping deep to the pretracheal fascia to find the thyroid gland. Thyroidectomies are standard fare in surgical training, but the vascular and neural relationships here dictate every single stroke of the scalpel.
Absolutely. I mean, to even see the thyroid, you have to deal with the infraoid strap muscles covering it. For a large obstructing goiter, you cannot just retract them. You sometimes have to physically divide the strap muscles.
And the motor supply to those strap muscles comes from the ansa cervicalis, which is a nerve loop from cervical roots 1, 2, and 3. If a surgeon decides to cut the strap muscles for exposure, they must make the cut in the upper half of the muscle belly. Why specifically the upper half?
Because the branches of the ansa cervicalis route downward and they enter the muscle fibers in their lower half. If you cut the muscle in its upper half, you preserve the entire neural imprint to the bulk of the tissue below the cut.
Got it.
When you suture it back together, it still functions. But if you cut low, you sever the nerves before they even enter the muscle, paralyzing the strap muscles and severely impairing the mechanics of swallowing.
The real high-stakes maneuvering in a thyroidectomy, however, involves the blood supply. The gland is highly vascularized by the superior and inferior thyroid arteries, and each one runs intimately with a nerve that you simply cannot afford to cut.
No room for error. The superior thyroid artery branches off the external carotid and descends to the upper pole of the gland. Running right alongside it in that incredibly tight space is the external branch of the superior laryngeal nerve.
Very close quarters.
Extremely. Because they are so close together superiorly but fan out near the gland, you must ligate the superior thyroid artery as close to the thyroid tissue as physically possible.
Okay, wait. I want to pose the scenario here.
Yeah.
Let's say a resident is rushing, ligates the superior thyroid artery a few centimeters too high, and inadvertently catches the external branch of the superior laryngeal nerve in the thigh. What is the specific mechanical failure in the larynx, and how does it sound?
So the external branch is entirely motor, and it innervates exactly one muscle, the cricothyroid muscle. The cricothyroid acts as a tensioner. It rocks the thyroid cartilage forward on the cricoid ring, which stretches the vocal cords tight, like a guitar string.
So if it's paralyzed, the string just goes slack.
Exactly. The vocal cord loses its tension. Now, the patient won't suffer complete hoarseness that happens if you cut the recurrent laryngeal nerve. Instead, they lose the ability to project their voice and hit high pitches. Their voice sounds weak, it's easily fatigued, and it's permanently deeper.
Good to know. Now let's contrast that with the inferior thyroid artery down at the lower pole.
The inferior thyroid artery approaches the gland from the thyrocervical trunk. It is intimately related to the recurrent laryngeal nerve, which ascends from the chest. However, the rule of ligation here is the exact opposite.
Why is that?
Because the artery and the nerve cross paths much deeper in the neck, away from the gland. So you must ligate the inferior thyroid artery, laterally, far away from the thyroid tissue.
So, superior close, inferior far.
That's the rule.
Let's move from the anterior neck and wrap completely around to the posterior structural axis of the body, the vertebral column.
Radiculopathies caused by intervertebral disc prolapse form a massive portion of the surgical exams. They really do. The vertebral column has a somewhat contradictory job. It has to be flexible enough to allow movement, but strong enough to bear weight and protect the spinal cord. The intervertebral discs act as the shock absorbers between the vertebral bodies.
Right, and the structural model for the disc is the classic jelly donut. The dough is the annulus fibrosus, which is a tough, fibrous outer ring. The jelly in the center is the nucleus pulposus, a highly gelatinous core. Under severe mechanical stress, the dough tears and the jelly herniates out.
And structurally, the annulus fibrosus is much thinner posteriorly. Furthermore, the posterior longitudinal ligament, which runs straight down the back of the vertebral bodies, doesn't fully cover the lateral edges of the discs.
So there's a weak spot.
Yeah, therefore, the path of least resistance for that herniating nucleus pulposus is usually posterolateral.
And when it herniates posterolaterally, it compresses the nerve roots. This brings us to a concept that causes immense confusion on the wards exiting versus transiting nerve roots. Let's walk through the physical path. Say the L4, L5 disc ruptures posterolaterally, a paracentral prolapse. It is incredibly counterintuitive. But an L4, L5 rupture typically spares the L4 nerve and hits the L5 nerve instead. Explain the spatial routing that makes that happen.
It is entirely about the geometry of the neural exit. The nerve roots don't just exit straight out, they angle downward. The L4 nerve root exits the spinal canal through the intervertebral foramen that sits above the L4, L5 disc space.
Okay, above it.
It tucks tightly up under the bony pedicle of the L4 vertebra. Because it exits above the disc, it is already out of the canal before the disc even herniates. We call L4 the exiting root at this level.
So it's tucked away safely. So what nerve is actually sitting in the danger zone behind the L4, L5 disc?
That would be the L5 nerve root. The L5 root is still inside the dural sac, traveling downward, preparing to exit at the next level down the L5S1 foramen. To get there, it has to vertically cross over the posterior aspect of the L4, L5 disc space.
Right.
We call L5 the transiting root at this level. When that paracentral herniation pushes back and laterally, it completely misses the exiting L4 root above it and violently compresses the transiting L5 root against the bony canal.
The lesion hits the transiting root. So an L4, L5 paracentral prolapse causes an L5 radiculopathy. What are the mechanical signs we see during a neurological exam?
Well, an L5 radiculopathy heavily affects the motor supply to the front of the leg. You will see weakness in ankle dorsiflexion and big toe extension, which results in a foot drop. Sensory-wise, the patient will report numbness over the lower lateral aspect of the leg and the medial side of the foot.
Now let's drop down one level. An L5S1 paracentral prolapse will compress the S1 transiting root.
And the clinical picture changes completely. S1 supplies the posterior leg. The ankle jerk reflex will be severely diminished or entirely absent. Motor-wise, you will see weakness in the everders of the foot, and the numbness will be localized to the lateral edge of the foot.
That covers posterolateral herniations perfectly. But what happens if the annulus tears directly in the midline and the disc ruptures straight backward into the central spinal canal?
In the lumbar spine, a central disc prolapse is devastating. The spinal cord itself ends higher up, usually around L1 or L2. Below that, the canal is filled with the cauda equina, the massive bundle of descending lumbar and sacral nerve roots. A central prolapse compresses that entire bundle all at once.
Mechanically shutting off the sacral outflow. This isn't just severe back pain. This is cauda equina syndrome.
It is an absolute surgical emergency. The sacral roots control vital autonomic and sphincter functions. The patient will present with saddle anesthesia, profound numbness in the groin, buttocks, and perineum. They lose anal sphincter tone, the anal wink reflex disappears, and the bladder loses motor function.
Causing painless urinary retention, right?
Yes, painless retention and overflow incontinence. If the pressure isn't surgically decompressed within hours, that neurological damage is permanent.
Wow. We have covered a massive amount of surgical territory today, from the embryological branchial arches all the way to the cranial foramina, traversing the fascial planes of the neck, navigating the thyroid vasculature, and finally tracing the spinal nerves down to the cauda equina. As we wrap up this review, I'll pass it over for a final thought.
Before we sign off, I really want to leave you with a biomechanical curiosity that directly connects our very first topic, embryology, with our last topic, the spine.
Oh, interesting.
Yeah, during embryological development, up to about the 3rd month of fetal life, the spinal cord actually occupies the entire length of the vertebral canal. But as the fetus grows, the vertebral bone grows vastly faster than the neural tissue. The spine effectively elongates and pulls away from the cord, which is exactly why the adult spinal cord ends high up at L1 or L2.
Because the bone outpaced it.
Exactly. But consider what happens in a developmental anomaly like spina bifida, specifically a meningomyelocele. In this condition, the neural tube fails to close, and the lower end of the spinal cord becomes physically tethered to the surrounding tissues in the lower back.
Oh, I see where this is going.
Now, imagine that child's vertebral column trying to grow normally. The bones rapidly elongate, but the spinal cord is firmly anchored at the bottom. This differential growth creates a massive, relentless downward traction force on the entire central nervous system.
It just yanks it down.
It is a mechanical nightmare. That tethering force at the base of the spine literally pulls the hindbrain, the cerebellum, and the brainstem downward through the foramen magnum at the base of the skull.
Creating an Arnold-Chiari malformation.
Yes, and because that brain tissue becomes physically wedged into the bony bottleneck of the foramen magnum, it plugs the hole, severely interfering with the circulation of cerebrospinal fluid, which frequently leads to hydrocephalus.
That is incredible.
It perfectly illustrates how an embryological tethering in the lumbar spine can trigger a catastrophic biomechanical failure all the way up at the base of the skull. It's a fascinating dynamic to explore on your own.
Everything is structurally connected. We'd love to hear your thoughts on this. Please leave a comment or a question about today's surgical anatomy review wherever you are listening. And as you head back to the wards or the simulation lab, remember that two-dimensional atlas is a great starting point, but out there, it is a three-dimensional minefield. Learn to look for the tripwires. Good luck with your revision.